Okay. Causes can be environmental, viral, they could be allergic to certain things, or it could also be genetic. What do you think is going on with asthma? What happens in the airways? Narrowing of the airways, bronchial constriction. So how do we know how the patient's doing? So there's certain things, peak expiratory flow rate monitoring is, you all know what incentive spirometry is after surgery, right? Kind of the same thing. So if the kid goes home and they do these every day, a decrease in their personal best will happen before asthma symptoms will occur. So if they're doing this every day and they seem healthy, say their personal best was, I don't know, shoot me a number. 500, and all of a sudden they're getting 300. There's no symptoms yet, but this is telling you something's going on that we may want to intervene before they actually go into a respiratory distress. Okay? We'll watch a video here in just a second. Medication-wise, so there's different categories, and I don't point out Pearson very often, but I will point it out on this point of asthma because it does do a pretty good job. So they classify asthma based upon the symptoms the child's having, how many times they're awakened at night, how much it interferes with their daily life, and how many times they have to take their short-acting medications such as their albuterol. Okay? It's a different classification based upon their age, 0 to 4 or 5 years and older. Okay? So I'm going to give you two ends of the extreme. Mild or intermittent. They have less than 2 episodes a week, no night awakenings, no short-acting medication use, and no activity interference. So very mild case of asthma. What do you think your medication intervention is going to be for that? Yeah, they're going to have an inhaler. They happen to have an acute episode, they can use that, it'll go away, and it's well controlled in between times. But they're not using that inhaler very often. Okay? Right. Other end of the extreme, severe. They have asthma problems throughout the day. They're awakened at night greater than 1 time per week. They're using their short-acting albuterol several times a day, and activity is extremely limited. Okay? Now you're looking at, they have the PRN inhaler and then plus medications on top of that. Okay? So short-acting quick relief, we mentioned the short-acting beta-2 agonist albuterol. It relaxes smooth muscle and causes rapid bronchodilation. Side effects, tachycardia and nervousness. So these kids will be blah. Some people you'll hear that are addicted to their inhaler because of they like the feeling that it gives them. If they're using it more than 2 days per week, additional therapy is needed. So no rule of thumb. Also for quick relief, if the short-acting did not work, if the albuterol does not work, you can add a corticosteroid. But it's only going to help in addition to, so you don't automatically skip the albuterol and go to corticosteroid. Okay? But it can enhance the effect of the albuterol. You want to give with food and give in the morning, so your body's natural production of corticosteroids happens in the morning. So if you give the artificial form in the morning, the body does better with that.
What do you do about their sugar?
Make sure you monitor their blood sugar closely because it can, usually it's long-term use that affects it more greatly, but anybody on corticosteroids, it can cause unstable blood sugar. So you want to make sure you monitor that. What else can it cause? Long-term wise.
Puberty-wise?
Decreased growth. Yep. Weight gain because people are extremely hungry. They're extremely irritable. So you have these kids, depending upon their age, now all of a sudden they're getting really irritable. So the parenting concerns grow. The stress in the family grows. It can also cause immunosuppression.
How to use a peak flow meter. Slide the marker or arrow on the peak flow meter to the bottom of the numbered scale. Stand up straight. Take a deep breath. Put the mouthpiece of the peak flow meter into your mouth, tongue down. Close your lips tightly around the mouthpiece. In one breath, blow out as hard and as quickly as possible, like you're blowing out candles on a birthday cake. The marker should move along the numbered scale. Note the number in your peak flow diary. Thank you for viewing this video from the American Lung Association.
There's all different types. I actually had an example of one. I can't find it. Maybe I'll bring it next week and I'll find it in my cabinet. But it's a little circle thing that's easy to pack in a purse or whatnot, where they can take it with them to do this. So it's not something big they have to have at home. Nebulizer. So what do you think of when you think of a nebulizer treatment? Y'all seen them? Okay, so if you think of respiratory therapy sometimes coming in a hospital setting, long-term care, the nurses may be doing it. The aerosol that kind of sprays around, right?
Thank you for choosing MedQuip for your respiratory needs. We appreciate your business. If your physician has recommended taking a respiratory medication with a compressor nebulizer system, please watch this video for instructions on how to properly use it. Compressor nebulizer systems provide air pressure that works with your nebulizer cup to turn liquid medications into a fine mist. This allows the medication to go directly into your lungs. Always wash your hands before setting up your nebulizer. Place your nebulizer on a hard surface, such as a table or countertop. Plug your nebulizer into an electrical outlet. Make sure the vents on either side of the unit are not blocked to allow necessary airflow into the compressor. Connect one end of the tubing to your compressor and the other end of the tubing to the bottom of the medication cup. Open your medication cup by twisting the lid and add the medication prescribed by your healthcare provider. Make sure you add the medication along the side and not down the center of the cup. Replace the top on the medication cup. Then connect either a mouthpiece or mask attachment to the medication cup. Do not lay the medication cup on its side. This will cause the medication to spill. You are now ready to begin your treatment. To begin your treatment, turn the power switch to the on position. The nebulizer will turn the medication into a mist. Place the mouthpiece in your mouth, or if you are using a mask, place the mask over your nose and mouth. Be sure to sit upright and remain relaxed. It is important to breathe through your mouth and not through your nose. This will ensure that the medication gets into your lungs. Take 2 or 3 slow, deep breaths in between each normal breath. If you must stop before completing the entire treatment, turn off the compressor. Depending on the type of nebulizer you have, treatment time should take anywhere from 8 to 15 minutes. You will notice a sputtering sound and will no longer be able to see the mist when the treatment is complete. It is okay if there are a few drops of medicine still in the cup. When your treatment is complete, turn off your compressor by turning the power switch to the off position. Then unplug the unit. The medication cup and mouthpiece or mask needs to be cleaned between each treatment. Disconnect the mask or
Okay. Then the next type, the meter dose inhaler. So you're thinking about the albuterol or the inhalers that people carry with them. Okay. ATI actually has an excellent video as far as how to instruct a patient how to use that. The problem is this computer still will not let me activate the Adobe Flash Reader, so I can't show it. But it's only a couple minutes long. It's under the pediatric portion, and it's either under asthma or MDI. One of them you click and it goes to some old man's diabetes assessment, and the other one you click, it goes to this. So try both of them. What do you think a kid that won't actually put their mouth up against the inhaler, what do you think you add to it to make it more easy for them to?
Flavors.
A spacer. And that goes through that. It's like 2 minutes long, so. So the next chronic respiratory tract disorder, cystic fibrosis. So it's a dysfunction of the exocrine glands that cause the glands to produce thick, tenacious mucus that pretty much hardens everything in the body. Okay, secretion, stool, everything ends up just hardening. Pancreas involvement, lung involvement, sweat gland involvement. Its diagnosis is made based upon assessment findings, so signs and symptoms, and then a positive sweat test, which we'll watch a short video on. They can also do a stool analysis, pulmonary testing, because if the mucus is hardened and thick, obviously the lungs get thick, kind of like a concrete wall, and they can't expand as well. Anybody know anybody with cystic fibrosis? Okay, about the same number in the morning class. I know 3 people. One's in their upper 30s, one's about 19 or 20, and the other one was 10 and died 2 years ago.
I knew a couple, they both died though.
They both
The
did?
oldest one was like 26.
Yeah, so the lifespan, they go through the cost, I can't imagine the cost, but of their medications that they take daily, their respiratory interventions, their chest percussion therapy that they have at home, but their lifespan, usually you'll hear like early 20s, but with treatment, then, I mean, some are living longer. So like I said, I know one that's in his upper 30s. So.
The one I know, she had a lung transplant.
Really? How do you think you get cystic fibrosis?
You're born with it.
You're born with it. It's genetic. It's recessively inherited. So 2 people can get together and have a kid and not know that they're carriers of this and pass it on to their kiddo. But both parents have to be carriers in order for the kiddo to get it. Now, if one parent has the disease and the other one's a carrier, then it's still possible. But if you have 2 healthy individuals have a baby with cystic fibrosis, they're both carriers of the gene. Nutrition's a big, so they'll have poor weight gain, failure to thrive for kiddos. They want small, high-calorie meals, but their pancreas does not excrete the enzymes that they need, the fat-soluble enzymes A, D, and E, I believe it is. So they have to supplement those. I'll show you sweat testing first, and then we'll look at the kiddos with it.
What, Black Friday now?
Now, I will say, minus the Black Friday ad, when the video first comes on, you're going to say, wow, this guy's really dull. But it's only 3 minutes, and it is good information, so listen anyway.
Greg's got it. Get 0 down, 0 interest for 36 months. Up to 35% off store-wide. Plus, save up to an extra $500 on appliances at H.H. Gregg. Greg's got it.
Your physician is concerned that the symptoms you or your child has may be caused by cystic fibrosis. Cystic fibrosis, referred to as CF, is an inherited disorder involving the lungs, intestines, and sweat glands. The main features of CF include progressive lung disease, failure of the pancreas to produce digestive enzymes, and excessive amounts of salt in the sweat. CF is an inherited disease, present at birth. It is not caught, nor can a patient give it to someone else. Most people with CF are diagnosed in the first 3 years of life. However, some children do not develop symptoms until later in childhood or adolescence. The symptoms and severity of CF can vary greatly from person to person. Very few people, less than 1 in 3,000, have cystic fibrosis, but it is something that must be considered in patient evaluation. Most of the tests that we do show normal results. CF is diagnosed on the basis of symptoms along with a positive sweat test. The sweat test consists of measuring the amount of salt, specifically chloride, in sweat. Patients with CF have a normal amount of sweat but the sodium and chloride content is high. The sweat test is used only to determine whether or not a child has CF. In general, it cannot be used to predict the severity of the disease. We will outline the steps involved in the sweat chloride test so you will understand how it will be done on you or your child.
Patients can eat a normal diet on the day of the test. There are no needles involved in the procedure. First, the technician washes the patient's arm and applies a piece of gauze or gel disc containing pilocarpine to the forearm. Pilocarpine is a drug that stimulates sweating. Another piece of gauze or gel disc is placed on the patient's upper arm. Electrodes are placed over the gauze pads and a mild current is applied for 5 minutes. The current feels warm or tingling, but not like a shock. After 5 minutes, the electrodes are removed and the arm is washed and dried. A dry piece of gauze is placed on the forearm and covered with plastic or collecting coil apparatus is applied. Sweat is collected for 30 minutes. The entire process may be repeated on the other arm. After 30 minutes, the gauze or coil is removed and sent to the laboratory for chloride analysis. The risk to the patient for injury is remote. Less than 1% of patients may have a mild localized reaction. Occasionally, an adequate sweat sample for analysis cannot be obtained, and the test will need to be repeated on another day.
Okay, so how do we diagnose it?
Sweat test and symptoms.
Very good. The pancreatic enzymes that I had mentioned, I said A, D, and E. It's A, D, E, and K that has to be supplemented, and it has to be administered 30 minutes prior to eating. A, D, E, and K.
Join us in supporting our nation's veterans. Little by little, we can all do a lot.
This is just to show you your patient with cystic fibrosis, not for you to donate money, I promise.
My name is Harrison, and I wanted to put this video together to show you what we have to do every day.
Why do you have to take all these medicines every day?
Because we have cystic fibrosis.
And you want to help by sharing with people what cystic fibrosis is and what you have to do?
I'm Jensen, and he's on medicine. This is my Flonase. I take these for my nasal allergies.
There's the vest?
Yeah.
You like wearing the vest?
No, but
What does the vest feel like?
wiggly.
Wiggly?
Yeah.
Does it hurt?
It hurts my chest a lot.
When do you have to take those?
When I eat my enzymes and my vitamins.
And the enzymes help you absorb food? How many enzymes do you have to take?
6 with every meal, 3 with snacks.
And what does it look like over here?
This is how many pills I take a day. This is how many pills I take a week. This is how many pills I take a month.
Wow.
And these are my little brothers.
And what is this machine over here, the vest? What does that do?
This is the vest machine. I put this belt around my stomach, and then it jiggles me, and I don't really like it because it hurts, because it jiggles me a lot.
And what does it help do?
It helps me clear out all the bad stuff.
Okay. Do you want to get better?
Yes.
Do you want people to help?
Yes. And I don't feel good, so I don't feel good.
You don't feel good?
I don't feel good.
So all these medicines, do you have to take all these medicines every day?
Yes. So, this is a nebulizer.
Okay.
It takes this, and I put it up to my mouth, and then I inhale.
Which medicines go in there?
3 medications.
Okay.
And each one takes about 10 minutes. This is the albuterol.
Okay.
It takes about 10 minutes.
Okay.
This is the Parmesan.
And what does the Parmesan do?
It helps me clear out all the bad stuff in my chest.
Okay.
And this is a hypertonic saline, which is probably my least favorite because it makes me cough a lot. It makes my chest hurt. And I really don't like it.
Does it make you want to throw up?
Yeah,
Do you throw up sometimes?
sometimes.
Yeah. So this is everything that you have to take on a daily basis?
Mm-hmm.
Wow. What do you think about cystic fibrosis?
I don't like it.
No? You want to help find a cure?
Please find a cure. So please donate money to cfstarfighters.com. Thank you.
So we'll see what goes away.
Okay, so you can, it's a lot of typing up in there, but you can see the chest percussion vest that they wear to loosen up that mucus. So that's for your cystic fibrosis patients, where percussion can be done for any patient that's got thick mucus, even with, vibration with your hands or a tapping on the back or whatnot, manual. But these are the actual vests for I think of it when I think of the cystic fibrosis patients, so. This is, I believe, a short video showing a lady doing like a manual chest percussion. That's the same video we just watched. I don't know how it got on here twice. Whooping cough. So we talked about whooping cough briefly when we talked about immunizations. Because we know it can be spread. The big thing, as far as respiratory-wise, that I want you to know is that immunizations can prevent this. It's increasing in incidence due to the population needing a booster shot, the Tdap. And it's important that we educate adult caregivers, pregnant ladies, whatnot, that they need this booster shot to keep the kids from getting whooping cough. So the adult caregivers could be carriers of whooping cough. It doesn't bother them because they have a more mature airway. They have more alveoli. They have all this stuff that works properly. Where we talked about the differences in pediatric patients is they don't have all that stuff. They don't have a fully developed airway. So it may affect them where it doesn't affect the adults. So as long as we give a booster shot to the adult caregivers, we should see this decline again. Immunization, so immunize the kiddos at around 2 months of age, and then encourage your adults to get the booster. Briefly touch on these 3 respiratory issues. So apnea, so we talked about infants can go as long as 15 seconds without breathing, so they can have apneic episodes up to 15 seconds. As long as there's no other signs, they're pink and all's good, and they start breathing again after 14 and a half seconds, then that's normal. Okay? So an actual apneic spell is defined as greater than 20 seconds. However, if you have an infant that stops breathing for 10 seconds and is blue, well, please go ahead and intervene. Don't wait 10 more seconds to clarify. Obstructive sleep apnea is the same as you think of for an adult, okay? It obstructs their airway when they're sleeping. It affects 1 to 3% of school-age kids. So we're seeing an increase in childhood obesity, so this could lead to this. Routine questioning to parents should be done. Do they snore a lot? Okay, so you all probably know from going to the doctor's office, they're asking that routine question to adults. We should ask that routine question for kiddos too. So even if it's not caused from obesity, what do you think kids could have that may be causing this? Yeah, tonsillitis. So they may need their tonsils removed, and may help with that problem. And the infantile apnea, again, is the less than 15 seconds. I don't know why I put that separate from the other apnea, but I didn't. Sudden infant death syndrome. So there's a few slides here that kind of beat home the same topic over and over and over again. So those are probably pretty important education topics we want to tell the parents. And prevention is key here. The definition of sudden infant death syndrome, the cause is unknown. That's the thing. We really don't know what causes it. It may be abnormality in the brainstem, causing neurological regulation of cardiorespiratory control not to function properly. But we don't know. It's unknown. There are risk factors. Maternal smoking, secondhand smoke, drug use, young maternal age, low birth weight, prematurity, if there are multiple, so twins, triplets, quadruplets. If they had a brother or sister who died of SIDS, short time between pregnancies, late or no prenatal care. It most frequently occurs in between 2 and 4 months. More common in winter. It occurs while sleeping. More common in males and higher incidence in certain ethnicities. Now, you could meet every single one of these criteria and not die of SIDS. Again, we really don't know what causes it, but we do know that these are increased risk factors. Sleep factors, so these are contributing factors to SIDS. So prone position, what position is that? On the belly. Yeah. So that lying on their belly to go to sleep will actually increase the incidence of SIDS. Soft bedding, bumper pads, and stuffed animals, overheating, and co-sleeping. When the child's discovered, they'll be apneic, blue, lifeless. They'll have frothy blood-tinged fluid in the nose and or mouth. So my story about co-sleeping is, so we want to model good behaviors in the hospital, right? We want to say no co-sleeping in the hospital. Go in, you walk in, the baby's in the bed with the mom. You say that's not, you need to put the baby in the crib while you're asleep because we don't co-sleep here in the hospital. We walked in on a mother before at Floyd Memorial with a dead baby in the bed.
They told me about that when I had my son.
Oh, they did?
Yes, they did.
But it wasn't me, was it?
I don't know if
No.
I had you, but
It was not
I don't
me.
think it was you.
But yes, so it has happened. There was blood-tinged fluid in the nose of this kiddo. Again, not what you want to find in a hospital setting or anywhere. May be found in any position, but typically they are in a bed that's kind of disshuffled with blankets and head, and they're huddled in a corner. They may be grasping something such as bedding, and diaper wet, wet and full of stool. So what do adults do most of the time when they die? They defecate or urinate, and babies do the same thing. So, education, always put them back to sleep. So, back to sleep campaign, always put them on their back. Never place in the prone position. Tummy time is important, but for play and as long as it's observed. If they're on their back, They awaken more easily, they have more sleep transitions, lower arousal threshold, meaning if they stop breathing, they tend to wake themselves up easier if they're on their back. Never use pillows, stuffed animals, quilts, soft, moldable mattress. Remove all this extra stuff. Avoid overheating. Swaddle loosely, so if you swaddle tightly, it can cause them to overheat, which would increase their incidence of SIDS. You can use a fan in the room. And I said in the earlier class, now newborns, as soon as they come out, we worry about temperature regulation, we worry about keeping them warm, okay? Remember that increased incidence is 2 to 4 months of age, okay? So now, once they get that temperature regulation going, then we can start to encourage the light fan in the room, the loose swaddling, all that stuff. Never co-sleep. Pacifiers decreases the incidence of SIDS. So what about a breastfeeder? So breastfeeding decreases SIDS and pacifiers decrease SIDS. And we say don't use a pacifier for breastfeeding because of nipple confusion. So normally that is in the first few weeks when you're trying to establish that feeding routine and that breastfeeding of that infant, and then after that feeding routine is established, a few months down the road you can introduce a pacifier to decrease that risk. No smoking, no co-sleeping, fan. Like I said, there's a lot of repetitiveness here. They can sleep in the parent's room so the parent can observe them easily as long as they're not co-sleeping with them, so in a separate crib. And there are several questions here on your slide that you all can use to practice. It's not just SIDS questions. Questions about respiratory?